We're going to talk about the distal radius and how deformity follows function. So let's just investigate how that not only applies to the hand, but also applies to the forearm axis and the elbow. And so the wrist is our solid platform for force transmission. And we know pretty well that it's an 84-16 split or an 80-20 split if you want to round off. And if it depends on the position of the wrist, but in general, it's about an 80-20 split for the radius to transmit the load up the arm, and it gets there via the ulna in a much less way. And so this axis goes through the radial head and the fovea centralis of the distal ulna. So we switch sides, so to speak, and the radius rotates around the fixed unit in the forearm. And so deformities at the distal end of the radius will affect this axis of rotation. And so even though the axis of rotation is these two items, the load-bearing column is really these two items. And so we have to take the load from the distal radius up to the elbow. And anything in the link of this system here, any link in the chain that's the weakest, is going to be the problem. And if this is the weakest link in the chain due to deformity, then the forearm is no stronger than the hand in this process. The ulnar plus variance changes as we rotate. So in pronation, a little more pronounced than in supination. And so that normal linear alignment is also important in malrotation and malunion of the distal radius. Here's our pivot point, our joint reactive force, distal radial ulnar joint. The ulna lifts the forearm. The radius doesn't lift the forearm. The ulna lifts the forearm via the brachialis. And so you're always lifting your radius and hence your radial carpal hand unit via this small joint here. And you have this small lever arm here, this huge lever arm here. And so the joint reactive force is quite large there at the distal radial ulnar joint, the seat of the ulna on the radius. And so that's one joint you have to pay attention to when the distal radius is malunited, malformed, maldirected, and not pointed at that pivot point on this fixed axis of longitudinal rotation, namely the forearm. And so we all know these radiographic criteria, and Nick Vedder and Doug Hanel, in their 20 years of practicing together, came up with an agreement that these are the kind of things we like to see with radial height, radial inclination, ulnar variance, and Palmar tilt. Now, a lot of people interchangeably use the word Palmar tilt with dorsal tilt because dorsal tilt is the pathologic state, Palmar tilt is the normal state, but many times we see that those two things are interchangeably talked about. Hans Kreter and all in 1996, Doug and Nick did this very nice article on how to make these measurements and where to make them, and gives us a nomenclature for measuring it, and also a position of the wrist and a standard radiographic criteria for measuring them. And then Schwind and others made some other nice drawings, but basically gave us a little bit more of how you can measure the translation of the radial shift or the ulnar shift of the carpus, and the carpal height ratio was thrown in to give us a better understanding of the ratio of carpal height to the third metacarpal to be able to correct between large framed individuals and smaller framed individuals. And so in the end, the radial angle goes to greater than 5 degrees, Palmar tilt neutral, ulnar variance is comparable to the other side, articular step off less than 1 or 2 millimeters, and the articular gap less than 2 millimeters. And this is a biggie. DRUJ is stable, and that's that axial alignment problem that we saw in Broner's study. So those are the end game that we'd like to see, that we'd say not malunion, not malformation. And so here's the one we don't want to see, and that's radial ulnar joint disrupted, radiocarpal joint severely disrupted as far as load bearing, intra-articular derangement, and ulnocarpal abutment. And so you got all three in one package. And those are the ones that give us the most trouble. But this lady came in not complaining about her wrist, but she was complaining about her sore CMC joint. So malunions of the radius are defined by Milch. Way back in 1953 when I was born, Milch was already talking about this, so it's no new kind of concept. But he said that malunions are basically fourfold. They're angulated, they're collapsed, they're rotated around that axis, and they're translated parallel to that axis. And so let's look at some of those findings. And so the three basic columns are the radial column, intermediate column, and the ulnar column. And if you want to break your malunions down, you can break them down into those three columns for better understanding. And then Charlie Malone gave us an idea that the intermediate column, i.e. the lunate fossa, can be looked at with two different pieces and two different zones of fracture and derangement. And what you get is articular step-off and the like. So malunions are angulated, so you have a loss of extension and flexion and supination if you have dorsal angulation. With radial angulation, you have loss of ulnar deviation. With collapse or telescoping along the longitudinal axis, you get ulnar variance positive, ulnar impaction problems. You lose ulnar deviation. Rotated around its longitudinal axis, you get supination deformity, loss of radial deviation. And translation in parallel to the longitudinal axis, you get loss of DRUJ offset and convergence of the ulna and the radius. And so let's look at angular malunion. And angular malunion not only gives us a midcarpal collapse that has been defined by a number of different authors, not the least of which is Margaret McQueen, but it's called a zigzag collapse or a dorsal shift. And you get uncovering of the acetabulum of the wrist, which is the capitate sitting on the lunate and the scaphoid. And so just like you get uncovering of the hip joint, you get uncovering of the midcarpal joint. It's a huge load-bearing axis inside the wrist. And once you have that, the whole chain starts to break down. And that lunate usually stays put, but it's the midcarpal joint that compensates for that dorsiflexion deformity. And what's dorsal and palmar angulation disrupts the DRUJ in addition to having a dorsally tilted radiocarpal joint. You obligatorily move the seat of the ulna on the radius in a dorsal pattern or a palmar pattern, and thus increase the force of ulnocarpal loading as well as radio-ulnar loading. And so with dorsal tilt, Short and Palmer from Syracuse looked at a long time ago how just a little bit of 10 degrees of dorsal tilt really shifts the load more on the dorsal side of the wrist, and their force diagrams show that just a little bit of dorsal tilt really increased the load on the load per unit area on the radius, and it really moved our load per unit area to the back side of the joint from a normal distribution here to a 28 degrees of dorsal tilt here, and you see the shift going throughout with contact pressures not measured as well as we do today, but this was a seminal article in regards to the carpal mechanics and dorsal tilt. We had known it, but they first quantified it. And so functional return after correction of dorsal angulation, this was wonderfully looked at by Margaret McQueen with just a number of about 23 patients, but really followed well. And she showed that function does return once you get this osteotomy done. And they looked quite carefully at the return of those parameters that I already outlined of our end game. And pain improved in all patients, activities of daily living improved in all patients. And in the SF-36, the two biggest improvements were roll physical and bodily pain in their 23 patients. And so she concluded with others that if you take it just from 20 degrees of dorsal tilt to 60 degrees of palmar tilt, you can really make an impact on functional outcome with distal radius fractures in these patients. These are almost all women also. The rotational problems are big, but Ishikawa and others looked at the location of the ulnar head in relationship to the sigmoid notch on the radius, the seat of the ulna on the radius. And with CT scan, they showed that once you traveled north, basically with Palmar, travel of the ulnar head on the radius, you restricted pronation, and with dorsal travel of the ulnar head on the radius, hence the radius flexes or extends, then you get these losses of supination. And so this article from 2005 really quantified for us with a very carefully measured out plain film radiographs followed by CT studies that with small amounts of dorsal tilt, you really lost the home of the ulna on the radius, and this was their measurement method with a very simple way of looking at the sigmoid notch and a very simple way of determining the center of rotation, i.e. about the fovea centralis of the distal ulna. And so as dorsal tilt increases and ulnar positive variance increases, it predictably led to loss of supination, and with Palmar tilt increase and shortening caused a predictable loss of pronation. And those two things weigh heavily on the Gartland and Worley score as well as the other risk scores. And so with these types of translations, you already see with just the normal slide and glide of the distal radial ulnar joint, it's not unlike the glenohumeral joint. You get this tremendous amount of displacement already just in the normal situation out here on the fringes of this joint. And so imagine that you have your wrist palmarly flexed or your radius palmarly flexed or dorsally flexed, and you're going to change that alignment quite a bit. And so with this small little spot weld here at the fovea centralis, those types of shifts get a lot of extra load. Stretching and injury to those ligaments can occur. And so with supination, you have the deep portion trying to hold back this radius on the ulna. And in pronation, you have the other side deep portion trying to hold the radius on the ulna. And so those deep ligaments are extremely important in their relationship on the bone here on the palmar side, or correction, on the dorsal side and the palmar side of the radial ulnar joint. And so with shortening of the radius on the ulna, you get not only this ulnocarpal impaction, but you also get this tremendous disability of the distal radial ulnar joint. And in addition, you hardly ever find the ulna south of the carpus. It's almost always sitting up on top of the carpus, pushing everything out palmarly in addition to its impaction. And so back to Andy Palmer and others, they said that 2 millimeters of shortening doubles the load across the ulnocarpal joint. And then shortening in kinematics with Brian Adams in 1993, he really had to make it really short in order for that change to take place. So it's almost always a little bit of shortening and a whole lot of dorsiflexion that gives you those types of defects of grip and with ulnar loading. So malunion involving the distal radius, it disrupts the DRUJ without injury to the TFCC. It causes pain and decreased function of the distal radial ulnar joint. So joint reaction force is the biggie for how we put together our ulnocarpal abutment understanding for the radiocarpal joint. But then for the ulnocarpal joint, we put a lot of load right here on the lunate. And so with ulnar variance as measured by a standard technique, you can quantify this, the easiest of all of them. So one area that's been of great interest in the literature recently is the CT osteoabsorptiometry. And say that real fast 3 times, but Makabe in this July in the Journal of Hand Surgery showed that pure radial shortening for elective radial shortening operations for Kienbach's disease, they looked at the density of the subchondral bone at a time distant to the healed radial shortening osteotomy, and they showed that preoperatively their subchondral bone had this density, and postoperative, red is dense, yellow is less dense, green is less dense, blue is less dense. And so post-op, that change was huge in the subchondral bone of the distal radius as measured by CT absorption. And so this was, to me, a functional outcome in the fact that the function of the distal radius becomes less as a load-bearing platform when you transfer that load with just a 3 millimeter radial shortening osteotomy. And so combined dorsal tilt and increased ulnar variance fared the worst of all studied in all age groups. And so translational malunions, you have disruption of the distal radial ulnar joint and disruption of the soft tissues with these type of translated fragments. The combination of articular fracture plus shortening is the worst. And in cases where you restore the radial translation, and you'll see this, it's hard to see, but it's the seat of the ulna going across the radius using this anti-glide plate or buttressing plate, getting this Shenton's line of the distal radial ulnar joint back to normal is one piece of malunion prevention. And with that comes the function of load transmission up to the elbow, and the weakest link in the chain being the deformed distal radius. And so functional deficits are greatest, as we talked about below. So thank you very much for your attention to this matter, and appreciate the opportunity to speak today. Thanks.
Doug will now talk about the difficult issue of distal radius malunions.
As we heard from Tom Fisher, if you have any distal radius fracture, I don't care how you got there, if that's your end result, then the problem is just the soft tissue healing. And that's that entity that takes that 8 months or so for people to resolve their pain after a distal radius injury. What's a malunion? You know, a malunion is anything that doesn't fit within those parameters. But most importantly, and I tell residents and fellows that if you turn this upside down and this was an ankle, this would be a crippling injury. But for this patient who presented to me for evaluation of her thumb CMC joint, it's this right here that's her problem, and not this deformity that has been present for the last 10 years. So the patient has got to recognize that it's a problem. Malunion types, they can be volar, dorsal, intra-articular. They can be loss of heights. And so a volar malunion is defined basically by a loss of all of those parameters. But most importantly, the patients present with a painful ulnar head or distal radial ulnar joint. And a similar correlate is with dorsal malunions. If you define that, you find that it's all those parameters, but the thing that really bothers them the most is a painful subluxed ulnar head, distal radial ulnar joint. So we're really just addressing the distal radial ulnar joint and the great majority of malunions. And this is true of intra-articular fractures or intra-articular malunions. For the most part, the troublesome intra-articular malunions are those that involve the sigmoid notch. Treatment? Well, the best treatment is don't get there, is to recognize volar instability and to recognize this very critical fracture that occurs in this volar medial corner, the so-called Malone fragment. And granted, unto itself, it only represents about 5% of fractures, intra-articular fractures of the distal radius, but it represents probably 90% of the referrals for malunion management that comes into our practice at Harborview. So, timing and indications of management of this. And I think the concept of the nascent malunion that was described by Jesse Jupiter and Diego Fernandez is you identify somebody who has a malunion, it isn't quite healed, now is the time to address it. And I think that if you address them early, as soon as you see them, then you can really reconstruct, especially intra-articular malunions, with relative ease. And so I think that waiting until they become solid and heal, like in the bad old days, is actually bad. I think that it's wrong to think that way. I think that we should chase these very early, especially the intra-articular fractures, and we do so. The patient obviously has to be stable and able. And one of the parameters that I think is really important to pay attention to is the fixed intercalary deformity of the radius. Document range of motion strength, and especially document sensibility. In evaluation, comparison films. The other wrist is your best template. It's better than any CT scan, I believe. But most importantly, if you have the ability to look at and make sure that this intercalary instability right here, this dizzy pattern, is indeed a compensatory intercalary pattern and not a fixed static pattern. Because if it's fixed and static and I do this osteotomy, I haven't done this patient much good. And so this is a prerequisite for doing osteotomies, the fact that the midcarpal joint remains supple. In my practice, I do use CT scans, especially for evaluation of intra-articular malunions. I like to use fluoroscopy a lot in evaluating these because it gives me a dynamic approach to evaluating these particular fractures and these malunions. In preoperative planning, I refer to the old article, and this is the original article by Rickley and Regazzoni. It's in the British Journal of Bone and Joint Surgery, and I'd recommend it for anybody. But what they do is they just divide things up into columns. There's a lateral column, that's the scaphoid fossa, radial styloid, lateral radius. There's an intermediate column, that is the lunate facet, sigmoid notch, and medial radial metaphysis. And then there's the distal ulna, which is the triangular fibrocartilage, and the distal radioulnar joint. And these three columns sit on top of one pedestal, and that's the metadiaphyseal bone. And each of these four, essentially, columns, or three columns in one pedestal, can have their own area of malunion. In evaluating these, I think that using and making a template is essential. You use your osteotomy as your pivot point. You need to make, and I just go where the fracture was. I think what we now have implants that now accommodate that, even in the most distal of fractures. And originally when we started doing osteotomies for these, we really had to pay close attention because if we made it too far distal, we had no real estate for our fixation. And now with the implants that are available to us, we can go through and recapitulate fractures and malunions by recapitulating the fracture. If it is extra-articular, I think the exposure through a classic Henry approach is appropriate. However, in intra-articular fractures, especially those that involve the sigmoid notch, I think that a more medial approach, the extended medial approach, gets you there better. Most of us are more familiar with volar anatomy. In the great majority of cases now, I am going volar rather than dorsal to fix these malunions. I will use lamina spreaders, use internal fixtures as provisional fixation. And the bone graft that I use is I don't use the iliac crest. Sohail Mirza, as a resident, looked at the complications of iliac crest bone graft, and they were so astronomical. And I was kind of like, oh, I'm never going to do that again. And I haven't since 1995 when he presented that study, and I use autogenous iliac crest bone graft either as structural, but for the most part it's just ground up bone chips. Provisional fixation leads to definitive fixation, and what kind of implants? Well, you know, I really don't care. It's the implants that you need in this particular job, and so the right ones for the right job. And I'd like to just show you a couple examples. This is an interesting case because having seen this, the patient gets referred to from physician 1 to physician 2. Physician 2 says, okay, well, here's what we're going to do. We're going to take it all apart, and then from lateral to medial, I'm going to try to capture this fracture fragment, put him in an external fixture. We'll leave it there for about 6-8 weeks and take this apart, and then he comes back to us with that. So it's kind of, rats. And so now he shows up as that physician 3, who happens to be me. And we look at that and you say, well, what does this need? And as you look at that, the implants that we chose was the same exposure, medial exposure, but this implant needed a little bit more structure to it and holding it. And this is just a pin plate or a volar pin plate that's made by Rob Medoff in a company that's called TriMed. But it takes advantage of something called a teardrop, or engaging the teardrop. So here's the osteotomy, here's the reduction, here's the teardrop reconstructed and held in place with this fixation plate. And you know, he goes on to heal, and he does lose some of his supination, which was vexing to him because he was a rock guitar player, and it actually inhibited some of his guitar playing abilities. So how about if you have an extra-articular fracture and you want to deal with that? Well, and this is a larger implant. I mean, and we're going to need something that's a little bit larger than what we've seen here. And this is 18 months post-op, and this is a patient that Dr. Bernershka and I shared with a malunion of her ankle or calcaneus and this distal radius. And in this setting, we have to address this pedestal. And in this case, the template is take the implant off through a volar approach, and then your template that you have that's where the implant should be. And so we put that on and we dial this into place. Now you've got all of this bone that you're missing right here. But because of the size of this implant, and the structure of having a double row of pins. This will hold this will hold here. I'm just going to take this and I'm just going to pack it full of this stuff right here, the cheap stuff. Cancellous bone chips packed tight and put into place. And we do that. We see that here. And then she goes on to heal. So finally, in the last column is the medial column, and distal ulna rarely unto itself is the problem. And for the most part, it's a length problem. And this is a patient who has healed short. And in this case, we do an ulnar shortening osteotomy. And I think that it's conceptually easy. They're technically difficult to do, just as a freehand maneuver, dumb thing to do. And there's a number of cutting devices that you can use. I actually just use freehand implements. I put a 3/5 plate on distally with 2 holes distally. I use a push-pull screw right here. I take a saw blade, and instead of going in 2 cuts, I use or take advantage of the kerf of a blade. And this is the kerf. And if you put the kerf on side, you can double the kerf, and if you put it at 60 degrees, as it hits bone, that equals 2 times the kerf. So you can make a 2 millimeter cut or a 3 millimeter cut. And when you're doing that, there's our plate, there's the kerf cut. We use this part with a DRUJ clamp to compress it in place. And arguably, this incision is longer than using templates. But I've never had anybody say that, this 6-inch incision is a lot better looking than this 8-inch incision. It just hasn't happened yet. I'm waiting for that to happen. So the kerf is cut. Lag the screw across, complete your proximal fixation. It's kind of embarrassing if you don't take out this screw right here. Yeah. How do I know that? So this is that implant. There's your fixation. Are there pitfalls? Yeah, if you put your proximal end of the plate off the bone, that's a pitfall. It becomes a prominent plate. If you think you can do this freehand, you can't. You need to have it set up for that. Creating a second path cut. You only want 1 cut, so you take advantage of the kerf of the blade. And you direct your osteotomy in the wrong direction. And instead of creating a crotch between the angle of the plate and the osteotomy, you do it just the opposite direction. I think that's wrong to do that. And that's what will happen if you do that. And so I think that's it. Thank you.